Hi there, my name is Ella Collins, and my capstone is on the nurse's role in maintaining neonatal glucose homeostasis. I did my preceptorship in the NICU at St. Joseph Medical Center, and one of the main reasons why I chose this topic is because neonatal hypoglycemia is a commonly encountered problem within the NICU and one that I encountered with my patients. Um, Also, I'm planning on becoming a labor and delivery nurse. And again, this is a problem that I'll encounter as a labor and delivery nurse. So I figured this would be a good way to mesh both the populations that I encountered in my preceptorship and that I will be working with throughout my future career. So, neonatal hypoglycemia is usually transient and is a normal part of the infant adapting to extrauterine life. Um, where we can see problems, though, is when the glucose levels drop below where we'd like them to into dangerous levels. Um, this can happen a lot in neonates that are at risk. So, at risk is preterm, late preterm, small for gestational age, large for gestational age, and infants of mothers with diabetes. These infants are more likely to have blood glucose levels that drop below um, our threshold, which for this presentation is 45. Um, and this can cause long-term neurological and developmental consequences if not treated properly. What surprised me in my research actually is that it's quite controversial where this threshold actually is. Um, there's a lot of different research pointing to different thresholds. And so the threshold that I went with is the American Academy of Pediatrics suggestion, which is 45. But a lot of other research institutes suggest either from 45 to 50, somewhere in that range for the first 48 hours of life. One of the main things I want to point out within my presentation is the interventions that we want to do to help raise those blood glucose levels. So, some great preventative measures that are non-invasive and non-pharmacological, breastfeeding and skin-to-skin contact. So breastfeeding and feeding in general help raise those blood glucose levels quite a bit. So by using it within the first hour of life or so, trying to get the baby on the breast, and then continued feeding can help maintain that glucose homeostasis. Skin-to-skin contact can also help thermoregulate and help encourage more breastfeeding. So these should be done in prevention and also to help treat alongside other interventions if needed. So if an infant's blood glucose levels drop below 45, our first step would be to use glucose gel because it's pretty much non-invasive. All it is just gel on the inside of their cheek. And it's rapid. It's been shown to really help maintain those glucose levels without invasive procedures. Our next step is if the baby is symptomatic or their blood glucose drops below a certain level, our next step would be to use IV glucose. Now, IV glucose is invasive. It is effective, but at St. Joseph's, you have to be admitted into the NICU to administer the glucose to the neonate. So this causes extra stress, extra costs. So making sure we're doing early interventions so we don't have to get to the point of IV glucose. But IV glucose is a great way, if needed, to raise those blood glucose values. So for discharge, we want the baby's glucose to be above 60 for at least 24 hours. It should be eventually above 70 after the first 48 hours and back to normal values for children and adults. But if this hypoglycemia persists farther than the first 48 hours, the provider might consider that it's more than transient and might look at a different diagnosis. I'd like to thank my preceptor, Angel Trinh, and the staff at St. Joseph NICU for their support. And thank you for listening to my capstone presentation.